I'm delighted to introduce our speaker for the day for this month's Journal Club. And we're very excited and honored to be joined by Dr. Evan Calabrese from UC San Francisco. And Evan is a physician scientist and a clinical fellow in the Division of Neuroradiology and the Department of Radiology and Biomedical Imaging at UCSF. Dr. Calabrese's research is focused on using innovative automated methods, including AI methods, to extract clinically useful information from multimodal neuroimaging data. During his training at UCSF, Dr. Calabrese has led several AI-based projects focused on topics ranging from image segmentation to image synthesis and radiogenomic inference. And today, Evan will be speaking about the feasibility of simulated post-contrast MRI of gliomas using 3D fully convolutional neural networks. And we're excited for this presentation. So please, Evan, welcome and take it away.
Okay, thanks so much. Thank you for the kind introduction. Very happy to be here. So yeah, I'll just get started. First with a little bit of background from this project. A lot of people, when they hear about this project, or when I talk to them about this project, they want to know if I'm trying to take down big gadolinium. They want to know if I think that gadolinium is bad, that we shouldn't be using it. And really, the short answer to that is no. And the longer answer is that gadolinium is really essential for many diagnoses in neuroradiology. It's kind of hard to imagine interpreting a study for intracranial infection or for brain tumor without gadolinium. And really, the agents that we're using now, the modern macrocyclic gadolinium contrast agents, are extremely safe. And there's been millions of doses administered to millions of patients with really a pretty good side effect profile. Definitely better than CT contrast agents and even better than a lot of medications that we commonly prescribe to people for other reasons. So these are important agents and they're really safe. So it's not so much, is gadolinium bad? It's, could no gadolinium be better? Would there be some benefits if we could get away without using it? And the truth is there are a lot of costs associated with gadolinium contrast agents. The agents themselves are expensive. Patients need IVs. You have to pay for physicians and nursing staff to be present when these medications are administered. There's also time costs. There's more time on the scanner to acquire these sequences. That takes technologist time, and you also have to consider physician and nursing time that could be used for other things. There's discomfort associated with the IV, with the injection of the medication itself. And while the safety profiles are really good, there still are some side effects ranging from minor discomfort to actual allergic reactions. Nephrogenic systemic fibrosis being sort of the most feared complication, but it's extremely rare now. And then gadolinium deposition, which we know happens in the brain and bones of patients over time, but we don't really know if there are any negative effects associated with that. And then finally, there's several special cases, patients who can't or won't receive contrast, pregnant patients, patients with severe kidney disease, or just patients who refuse, which I've noticed is becoming more common, at least here. And then there's also this sort of enticing idea of on-demand gadolinium contrast. What if we could just get free gadolinium contrast on our non-contrast studies? So this was a case that I saw not too long ago, a couple of weeks ago, a patient who came in for a non-contrast MRI and had this pretty benign appearing TT hyperintensities in their temporal lobes. It'd be kind of easy to blow these off, but we ended up recommending that the patient come back for gadolinium enhanced imaging. And it turned out that these were actually peripherally enhancing masses. And this was a patient with metastatic lung cancer that spread to the brain. So it would be really nice if we could sort of use on-demand free gadolinium contrast from simulated images to evaluate equivocal findings on non-contrast studies, maybe to screen for patients who need to come back and get a repeat study with contrast. And another idea would be to maybe use this type of technology to follow up known enhancing lesions. Patients, for example, who are getting tumor follow-ups for things like meningioma, where they're coming back for multiple studies, maybe we could save them extra doses of contrast. So that's a little bit of the motivation. And this is kind of how we summed it up in the manuscript, a little bit lengthy, but the idea here is if there's one sequence we could get rid of without compromising diagnostic accuracy, the post-contrast imaging would be the one because of all the costs and problems associated with it. And there's a theoretical basis for why we could be able to make simulated post-contrast images from non-contrast MRI. And that's really because MRI sequences are very highly correlated with each other. All of these sequences contain some amount of redundant information because they're all encompassing the same anatomy. And the T1 pre-contrast imaging in particular is very similar to post-contrast imaging, essentially the same scan parameters, with the only difference being the contrast agent itself. So it raises the question, can this enhancement be inferred based just on the non-contrast sequences? So the idea of this study, the kind of background idea, is to take multimodal non-contrast MRI, to feed it into some black box algorithm, and to get out a simulated post-contrast image that looks like and acts like, for all intents and purposes, real post-contrast imaging. So what is this black box? Well, it's essentially a regression method because we're taking some inputs and we're expecting a particular output. It has to be able to take multiple input variables because we want to give multiple different image contrasts. It has to be able to represent complex and nonlinear relationships between data. There's no reason for us to expect that the relationship between non-contrast MRI and post-contrast MRI is linear. In fact, I think it's more likely that it's not. Ideally, it would be able to draw contrast or context from adjacent anatomy because we are looking at images, so adjacent pixels do have some correlation with each other. So being able to draw from that spatial context is useful. And it also needs to be able to learn from and adapt to new data. So probably all recognize by now that these are all characteristics of deep convolutional neural networks, one of sort of the best black box algorithms that we have right now, and what we chose to use for this study. So with that, I'll get a little bit into more details of the methods for this project. So just broadly, our study design is that we had 400 patients with MRIs that had brain gliomas. We used a 10-fold cross-validation approach where we divided that set of patients. We took 90% of them to use the training set. And then we turned those hundreds of cases into tens of thousands of training examples through some data augmentation techniques. First, we chunked the data up into 80 by 80 by 80 pixel cubes. And then we performed random rotations and dimension swaps to really increase our training numbers. We then used that data to train a deep convolutional neural network to predict post-contrast images. And then we took the remaining 10% of our patients as a testing set. We took those non-contrast series, fed them into our trained neural network to generate synthetic post-contrast images. And then we performed some quantitative and qualitative comparisons between the real and synthetic images. It's kind of the broad overview. So here's a table from our article showing some of the patient characteristics. As I said, there were 400 patients, average age about 60, predominance of male patients, mostly glioblastomas. About 332 of them were glioblastomas with only 68 lower grade gliomas. And all these patients were imaged with the same standardized preoperative brain MRI protocol that includes these eight sequences that you're seeing here: a T1 pre-contrast, T2, T2 flare, diffusion, susceptibility, a 55 direction, Hardy DTI, arterial spin labeling, and then of course post-contrast imaging. And for our brain tumor protocol, actually most of these sequences are 3D with the exception of the diffusion sequences. All these other highlighted sequences are in 3D. So all this data then underwent an automated pre-processing pipeline through these steps here with the tools we used shown in gray below. We registered all of the images to a common space, in this case, the Montreal Neurologic Institute Atlas. We performed skull stripping to isolate the brain parenchyma with the tool we developed. Coil bias correction using N4 to correct for inhomogeneities in the images. And then we segmented the tumors into 3 compartments using some of the algorithms developed for the brain tumor segmentation challenge. So then These preprocessed images served as the inputs for our model for training. And we actually trained two separate models. We trained one that we're going to call the full model with all 8 of these contrasts. So the standard T1, T2, and flare, plus all these other extra sequences that we do, a total of 8. And then we did another one that we call the reduced model that just has sort of a more standard set of contrasts that you might see in any protocol, regardless of setting, T1 pre-contrast, T2, and flare. Here's our network architecture. As you can see, it's based on the popular UNet architecture. This one though is fully 3D and fully convolutional. So all of the downsampling steps are strided convolutions. All of the upsampling are transpose convolutions. And we have these long-range strip connections between the different links. And actually each of these blocks that I'm showing here is a bottleneck residual block borrowed from the ResNet article, where we have both a short range, a skip connection, and then a convolutional pathway that has value activation, batch normalization, and dropout. We trained this model on our NVIDIA DGX2 system here at the Center for Intelligent Imaging, sort of the UCSF counterpart to the AIMI. And this really incredible, powerful computer, it's got these 16 32 gigabyte cards. But even with this type of computer, this model being 3D and having so many trainable parameters is actually pretty difficult to fit into the memory space there. So we had to use a couple of optimization techniques. We used this mirrored distribution strategy that's available in TensorFlow, where we can put identical replicas of this model across multiple different GPUs and train them with different batches. And then there's a set of central variables that are updated after each step. So this basically just lets us increase our batch size by training on multiple GPUs at once. And then we also use this mixed precision data policy, where we can turn a lot of the 32-bit floating point variables used during training into 16-bit floating point, which has some penalty in accuracy, but provides pretty considerable memory savings on the order of like 40%, 50%, depending on how you structure your network. And those operations actually run a lot faster because they can run on these optimized tensor cores on NVIDIA GPUs. So some more details of the training. We used mean squared error as our loss metric. And that was actually for a couple of reasons. One is because the squared error really penalizes outliers a lot. And in trying to simulate post-contrast imaging, outliers are actually what we care about. The enhancing components of a post-contrast image are outliers. They're sort of way higher intensity than everything else. And also just that MSE sort of very favorable in terms of gradient profile. When error is high, the gradient is very steep, and then when error is low, it's very flat. So when training with MSE, the networks tend to converge without doing stuff like running or decay or anything like that. So we trained for 25 epochs across the entire data set. The batch size was 8 times 4 GPU replicas for an effective batch size of 32. We used the Atom optimizer and a dropout rate of 40% for training. And this took about 12 hours per training session. So not too long, but still was able to accept plenty of people by occupying 4 GPUs for 12 hours per session. Okay, so here are some of our results. There's side by side a real and a synthetic post-contrast image from the same patient, synthetic on the right here. And you can see that our synthetic results are just like the inputs, they're 3-dimensional, they're fully resliceable. And I think, it'll be obvious to you all, but side by side, you can tell the differences between these two. They're not identical, but they are very close, both in normal brain regions and within the tumor region itself. And here's some more of those results from one of the figures in our paper, showing the results for both low-grade tumors across the top here, and then Glioblastomas along the bottom 2 rows. Here's a couple of those magnified up. A grade 2 glioma over here with no abnormal enhancement, real images on the left, synthetic on the right. And then sort of a more typical glioblastoma, same thing here. So then we made all these synthetic images, and we're left with this really tough problem, which is how to actually quantitatively compare these real and synthetic images. And I'm guessing that some of you here have probably dealt with this problem before, but it's pretty challenging. And there's a ton of different metrics that are out there that you can use, but the question is which ones should you use and which ones make sense. And so in thinking about all these different metrics, we tried to narrow it down by focusing on a few criteria. We wanted the range of our metric to be between 0 and 1, just to aid in interpretability. We wanted them to be scale invariant, so we didn't want it to care whether our images range between 0 and 1 or between 0 and 32,000. And we wanted them to be linear scales, so we wanted a difference of 0.1 to mean the same thing, whether it was between 0 and 0.1 or whether it was between 0.9 and 1.0. So using those criteria, we picked some metrics to use to compare these two. And, you know, I think it's difficult to know which are the right metrics. So we picked quite a few. For error metrics, we picked these ones that I'm showing here, 4 different error metrics. And then for similarity metrics, we picked these. Structural similarity is one that has been used for similar work before. So that was one we thought was important. And then there's these other 2, cross-correlation and mutual information, which are actually implemented in this advanced normalization tools registration software that we use for image registration. That are very useful as well. So, but still, even with those criteria, I think these metrics are really hard to interpret. So I included in the supplement for this article, this table here where I took an image of a glioblastoma and corrupted it with varying levels of blur and noise and looked at what happened to these metrics. So here on the uncorrupted images, all the similarity metrics are 1, all the error metrics are 0, as you'd expect, and they change to varying degrees with these different corruptions. And some interesting stuff happens, like the structural similarity index drops dramatically, even with just a little bit of noise, goes down to 0.2, whereas you can blur it quite a bit and it will still remain pretty high. So sort of this table is sort of meant to help interpret these metrics that I think are pretty tough to interpret. So that being said, here is our results for our similarity metrics of our synthetic data. I think this figure is a little bit complicated, but I'm going to start just focusing on this portion of the chart, which is looking at these metrics across the whole brain. All of these metrics are comparing to the real post-contrast image. And you'll notice we have the real T1 pre-contrast as one of the columns. And that sort of serves as our baseline. As I kind of touched on before, the T1 pre-contrast image is already very highly correlated with post-contrast imagery. So, and that's reflected in these metrics here. So this is sort of the baseline. If we don't do better than the T1 pre-contrast, then we're not adding anything, and there's really no point. So that's why that's included here. And then these other 2 sets of bar graphs are our full network that was trained on all 8 image contrast, and our reduced network just trained on the T1, the T2, and the FAIR. And these asterisks here indicate that there's a statistically significant improvement compared to the T1 pre-contrast. So our synthetic images were significantly better in terms of similarity metrics. But interestingly, our reduced model was very close. It was not statistically distinguishable. You can see that it's slightly lower by all metrics, but it's very close just with the T1, T2, and FAIR as training inputs. So these results were across the whole brain. We also looked in the tumor region itself, so just in the area of signal abnormality. And here, again, very similar results, except that everything's lower. That's kind of as expected. You know, the tumor region is going to be the hardest region to predict because that's where there's the most heterogeneity and enhancement. So again, our synthetic model performed, our full model performed the best. The reduced model was very close, though indistinguishable, statistically at least, and they were both better than the T1 pre-contrast, as expected. And then focusing down even more narrowly just to the tumor core, the enhancing component of the tumor, ignoring all the surrounding FAIR abnormality. Again, similar results. All the metrics are worse. Still, the full model is better. And you can start to see there's an increasing separation between the full and the reduced model as we really hone in on the tumor core. So these are the results for the error metrics. Basically, a similar story on this part of the figure. It's just that everything's the inverse because error metrics, 0 is better, and similarity metrics 1 is better. So, but again, same thing. Synthetic model performed the best, was significantly better than the pre-contrast, and things get worse the more you hone into the tumor core itself. So we thought that quantitative analysis was important, but it's also a little bit esoteric in thinking about what a neuroradiologist actually cares about. The percentage error in the tumor is not something that a neuroradiologist would really think about. They would want to think more about what is the area of enhancing tumor, what should I be telling the surgeon that they should pay attention to. And so for that reason, we did this overlap analysis. And what we did here is we fed both our real and our synthetic images into our automated tumor segmentation algorithm. And as I said, that came from the brain tumor segmentation challenge. So it was trained on data, on only real data, right? It's never seen synthetic data before. So it should be segmented stuff, only stuff that looks like real enhancement. So we segmented both the real and synthetic images for each case. And then we looked at the overlap. So here, yellow is the real enhancing tumor segmentation, blue is the synthetic enhancing tumor segmentation, green is their overlap. And we use the DICE overlap coefficient. Again, with this metric, 1 is perfect. And we got, in this case, a value of 0.67. Here's several other real and synthetic tumors that we segmented, synthetic ones on the top. And this brightest color is the enhancing region. And across our set of 400 patients, we found a DICE overlap of about 0.7, or standard deviation of about 0.2, which I was actually really happy with. I think these enhancing regions are very thin and very irregular. And so I think that's actually a fairly respectable DICE coefficient. So a couple other things that we looked at briefly. We looked at differences in our performance in high-grade and low-grade tumors. And we found something kind of interesting. The low-grade synthetic images were actually worse, statistically worse, by all of our metrics compared to high-grade tumors. And at first I thought that was kind of strange because the low-grade tumors tend not to enhance. So it wasn't really clear to me why we would be having trouble with them. But, looking back at our training data, we only had about 70 low-grade tumors in our training data set, whereas we had about 330 high-grade tumors. So I think it really boils down to the fact that these low-grade tumors are underrepresented in the training data set. We also wanted to look at the relative contribution of the inputs. So which were the sequences that were most important for creating a good post-contrast result. And this is actually something that Jeff Rudy, one of the co-authors, pointed out to me. We already know that the T1 pre-contrast is going to be the most important. So the way we did this was we took the T1 pre-contrast and just added one other sequence, trained the model on those, and looked at how the performance was. And what we found was pretty interesting. Just T1 and T2 was enough to get a result that was statistically indistinguishable from our full model trained on all 8 sequences. Now that didn't pan out by all metrics. When we looked at the tumor core, here these stars are indicating that these 2 metrics, mutual information and cross correlation, were statistically worse for just T1 and T2. But the fact remains that T2 is the second most important behind just the regular T1, and it gives you a result that's very close to using all 8 sequences. The other thing I thought was interesting here was that arterial spin labeling, perfusion imaging, I really thought was going to be very important because it's providing something that none of the other images have, which is physiology, perfusion to the tumor. But that didn't really turn out. It ended up not being very important at all. Okay, so another aspect of this study was our reader study, where we had neuroradiologists qualitatively assess these images. To do this, we took 4 neuroradiologists with varying levels of attending experience. We assigned them 80 cases each, which were a random mix of real and synthetic cases, random mix of high and low grade tumors. We designed it such that all cases were reviewed by 2 different radiologists. and that both the real and synthetic images were reviewed for each case, but never by the same radiologist. And then we basically asked people to review these images and just answer these three simple questions. Do you think this is a glioblastoma or a low-grade glioma? Does it enhance? And is this a real or a simulated image? And we kind of use the real cases as the gold standard, which, you know, could argue is a problematic gold standard, but happy to know these four radiologists, they're the co-authors, and, you know, they're all amazing radiologists. So I think it's a really good gold standard. And then we used our synthetic cases as comparison. So here's some of the results of that study. You can see for the first two questions, for tumor grade and tumor enhancement, accuracy, precision, recall, all sort of in the 80 to 90% range. And the Cohen's kappa for integrated variability was very high for both of these also. That's in contrast to the final question, whether these were simulated or real images, where accuracy and precision and recall were sort of in the 50 to 60% range, and there was very poor integrated variability. I do think it's worth pointing out that some of the readers were able to do very well on this task. One reader in particular was able to get like 80% correct in determining simulated versus real. So I think this is something you can learn to do, but the fact is, you know, they're good enough to at least confuse a few very qualified neurologists when viewed in isolation. I think when you view them side by side, it's a different story. Okay, so the last thing I want to touch on is our external validation. So for this, we took an external data set, the brain tumor segmentation challenge data set from 2020. This is a publicly available data set. We took 286 of these cases, of which 221 were glioblastomas and 65 are lower grade gliomas. And we looked at these in two different ways. One was we trained a model using just T1, T2, and FLAIR from the UCSF data set, which are the only contrasts that are available in the BRATS data set. And then we evaluated or tested using the BRATS data, and we called that the external test. And then we did this refined test where we did the same thing. We trained the model with all of our UCSF data, but then we took 50% of the BRATS data and just trained it for 5 more epochs, so kind of like an hour, hour and a half more of training on half the BRATS data. And then we tested with the rest of the BRATS data. So here's some of the results, showing results from that sort of refined model. Again, lower grade tumors from the BRATS challenge data set and some higher grade tumors along the bottom 2 rows. There's 2 examples again, a low grade tumor without real abnormal enhancement and a more typical glioblastoma. Again, real images on the left and synthetic on the right. And we also did this error and similarity analysis. So just focusing on this part, you can see that testing on the external data set without refinement, we did take a pretty considerable hit in our similarity metrics. And I think this makes sense. The BRATS data set is very different. It's multi-site, some of it's 2D, some of it's 1.5 Tesla, compared to our data set, which is mostly 3D and 3 Tesla. So I think it makes sense that there's a big difference. But we were able to recover most of that performance by just training with a few more epochs using half of that BRATS data. So there was a pretty considerable transfer learning that happened here. And, you know, similar story with the error metrics. So where are we going in the future with this project? Well, there's a couple of really interesting things that came from this project, and one of them was the false positives. We did systematically look at the data to see if there were false positive enhancement, and we did identify these 5 cases. These 4 here, these 2 and these 2 on the bottom, were all low-grade tumors that did not enhance, but that the algorithm inappropriately assigned enhancement to. I think, you know, that may boil down to what I was talking about earlier, how we had a relatively small proportion of low-grade tumors in the training data set. So we may be able to fix that by adding more low-grade tumors. This one was pretty interesting. This was also a low-grade tumor, but this enhancement is not in the region of the tumor. It's sort of in a random spot in the anterior frontal lobe. So I'm not really sure what that's about. I think it kind of highlights the fact that these convolutional neural network algorithms can have some unexpected behavior sometimes. You need to sort of carefully look at the results. And then we also had some incidental true positive enhancement. So these were abnormal enhancement in the brains of these patients that were not related to their tumors. So this is a development of Venus anomaly in the cerebellum of a patient, a pituitary adenoma that we happened to catch, and a convexity meningioma. So to me, this suggests that this can work in other disease processes other than brain tumors. And also that training on gliomas actually gives some information about other enhancing stuff in the brain. So there's probably some considerable transfer learning approaches that could be applied in applying this to other disease processes. So, and then finally, one thing that we're looking at actually right now to try to improve this is using this generative adversarial network approach. In this case, we would use our same network that I've just described to generate synthetic cases, but instead of using mean squared error loss, we would use a discriminator network, which would try to distinguish real and synthetic images and use that to feed back into the generator and improve it. And then I also want to mention that I'm working with a super talented and smart resident here at UCSF, Dr. Maggie Chung, who's been working on applying this to breast cancer imaging. And she's got some really exciting initial results showing that this does work in breast imaging as well. So another future area. So that is all I have for the presentation. Just want to thank my co-authors, everybody here at UCSF, including the Center for Intelligent Imaging, and my funding sources. And I'd be very happy to discuss the paper with you guys.